Okay, I think to respect everybody's time, I think we should get started. I want to welcome everybody. Thank you for attending. My name is Chris Garcia again. I'm from the marketing team here at CeQur. And today I want to welcome you to our second national peer-to-peer webinar for our company. And the title of our presentation today is Removing Known Barriers to Mealtime Insulin Dosing. Before we move forward to the next slide, Diane, I just want to have a little seconds of have a little fun with you before we dive into the clinical education. I got a little quiz for you. So we have 3 top states. So fortunately, it's pretty awesome. We have folks dialing in from nationwide, various states across the country. But I want to quiz you on what you think the top 3 states are.
Oh, I did not know there was going to be a pop quiz. Okay.
Yeah, we got to make it a little fun.
So I have no idea, but I'm going to guess. I'm going to hope Ohio, maybe, since that's where I'm from. And then, I don't know, California is a big one. And let's see, what else should I go with? Florida.
Okay. So number 1 is Pennsylvania.
Ooh.
So thank you to all the folks from Pennsylvania dialing in. 2 is Massachusetts. And actually tied with Massachusetts is Georgia. And number 3 is Ohio.
Yes, well, I got 1. 1 for 3.
So with that being said, we're really excited. We have folks from nationwide dialing in. We've met a lot of you at the ADA booth, at the CDCES booth in Columbus, Ohio. A lot of folks were invited by our territory reps in various states nationwide. A lot of folks have seen our social media invitation online. So welcome all and thank you for being here. So let's get started. So next slide, please, Diana. So these are the items we're going to discuss today. We're going to first cover the unmet need in insulin delivery. So a little bit of the common challenges that our product CeQur Simplicity helps address. And then Diana's going to dive into the clinical data and user satisfaction data that we have for our product. And then lastly, we'll have time for summarizing. And most importantly, we have about 15 minutes of Q&A. So with that in mind, I just want to remind everybody to please ask questions throughout today's presentation in the chat box. My colleague, Curtis Carter from the marketing team, he's helping out in the chat box and we'll be addressing your questions. Diana and I will cover frequently asked questions at the end, and then we'll do our best to cover any additional questions that come in through the chat box that Curtis may have not addressed or that are worth to talk about, with Diana via discussion. So next slide. So it's my honor and excitement to introduce you all to Diana Isaacs. She is the Remote Monitoring and CGM Program Coordinator and Endocrinology Clinical Pharmacy Specialist at the Cleveland Clinic Diabetes Center. She earned her bachelor's degree in chemistry from the University of Illinois at Chicago, Doctor of Pharmacy degree from Southern Illinois University, Edwardsville, and completed residency at the Philadelphia VA Medical Center. Dr. Isaacs holds a board certification in pharmacotherapy, ambulatory care, and advanced diabetes management. So I want to thank you again, Diana, for joining us and looking forward to your presentation today. Just a few disclosures. This program is sponsored by CeQur, and the speaker is presenting on behalf of our company, CeQur. And next slide is, I just want to take the opportunity to let you all know what us folks at CeQur strive for. We strive to simplify the lives of people with diabetes and to revolutionize insulin delivery by providing convenient, discreet, and injection-free dosing. So without further ado, I'd like to pass the baton to Diana to have us talk about her presentation today, first starting with the unmet need in insulin delivery.
Great. Well, thank you so much for that introduction. And I want to thank the CeQur Simplicity team for inviting me to speak today. Just to give a little bit more background to everyone, because they may be thinking, oh, why is a pharmacist talking to us? So in my role, in Ohio, pharmacists have provider status. And so I'm actually able to prescribe. So I start patients on new therapies, including therapies like CeQur Simplicity. medications and work to adjust them. And I work in a adult endocrinology clinic. And one of the things that I really just advocate so much is patient choice. We have a lot of new options now, which is amazing in the diabetes space. But unfortunately, what I see is that there's a lot of disparities, that a lot of people are never told about these additional options and thus have no idea. And so that is something I really advocate. And I'm really excited that you've all have joined me today to learn about a potential new option for your patients. So let's just start with some background about diabetes. This is really a growing problem. In fact, the latest statistics from the CDC show that 11.3% of the United States population has diabetes. I mean, that is a huge number if you think about it. That means 1 in every 9 people. So we all know somebody with diabetes now. So why is it growing? Well, we don't 100% know, because it's really interesting. Most of the cases are type 2 diabetes, about 5 to 10% are type 1, but we're actually seeing the cases of type 1 diabetes increase as well. In fact, I'm getting more and more adults that are being diagnosed with type 1 diabetes. With type 2 diabetes, we know that there is a big link with obesity, and obesity rates are rising. I think the latest stats show that 70% of the US population either lives with overweight or obesity. So of course, there is a big link there. And why is this so important? Well, the longer people live with diabetes, with type 2 diabetes, the more likely that they're going to need to progress to use insulin. And we are seeing now, I mean, kids are being diagnosed with type 2 diabetes. And yes, we have some amazing medication therapies. We have the GLP-1 agonists, we have the SGLT2 inhibitors, but through the natural progression, if someone has been living with type 2 diabetes for 15, 20, 25, 30 years, the natural progression is that their beta cells in their pancreas are going to wear out and they are going to require the use of insulin. And so what we know is about 5 million people are currently taking insulin right now, and 2.4 million of those people are on mealtime insulin. These numbers are expected to rise. And the reality is insulin is the most effective tool at lowering A1C. With all of our other therapies, there's usually some maximum amount that it can lower A1C. With insulin, there is no maximum amount, although it does have a narrow therapeutic window. So we have to, of course, be careful how we're dosing it, but no maximum amount. So definitely can help our patients to be able to achieve A1C. Unfortunately, we are doing a terrible overall job in helping people to reach their A1C levels. So I also think the latest stats show that less than half people are able to reach the A1C of less than 7%, which is the most desirable optimal level to achieve. Of course, we increase that goal to less than 8% if we have challenges reaching the 7%. But even that, even when we individualize the goal, a lot of people are not able to reach that. So one of the big problems that we have is that when we do intensify therapy and we do add mealtime insulin, there are so many barriers to taking insulin. So most commonly, insulin is going to be injected. Yes, we have one inhaled form of insulin, but otherwise people are injecting insulin, right? And giving multiple injections throughout the day is not the most fun thing ever and is not always the easiest thing to do. So these statistics show that 72% of people do not take any insulin outside of the home, meaning they don't carry their insulin, they just don't take it. So if they're home, great, they'll take it. And this works well for someone who's on a once a day long-acting insulin. They'll take it at night, they'll take it in the morning. But when they're out during the day, they're out at work, they're out doing things, they're not taking that. And that's a really big number. 57% of people report missing injections that they knew they should take. So they knew maybe it was time for their lunchtime dose and made the decision, it's really not convenient for me to take this dose right now, I am not going to take it. Versus many people just forget to dose, right? This is showing 53% of people forgot to dose. And this is a scenario I see happen a lot. You know, someone is out, they get busy. It's kind of inconvenient to go grab the pen or grab the vial. And so it's easy to kind of forget. 40% just forgot to carry their insulin. And you'd be amazed how many very smart, savvy people, it's just easy to kind of forget that. And then 33% reported just skipping on purpose. Maybe it was an inconvenient time, you're at a business meeting, it's just not a convenient time. So why is this such a big deal? Well, missed insulin doses raise A1C. And unfortunately, we know that increased A1C increases the risk of diabetes complications. It also increases the total cost of care. So it's a big, big problem that we've had. So missed mealtime insulin doses do raise A1C. And what we know is that people spend about 12 hours every day in a postprandial state, meaning during the day, they're regularly eating meals. Did you know that missing even 4 missed mealtime doses over a week leads to a 0.92% increase in A1C? So basically a 1% increase in A1C just from missing 4 doses. And that is really easy to do. You just saw all those statistics about all the reasons people may forget or not take one of their mealtime doses. This is a really huge increase. So we've got to think about what strategies are there that we can use to help people to take their mealtime insulin so that they are not missing it. So also, missed mealtime doses can really be costly to the whole healthcare system. And there's a lot of emphasis, there's a lot of interest in, okay, how can we improve diabetes outcomes? We see all of these population health initiatives, like trying to target higher risk people, getting them in for more frequent visits. The statistics show that a person with diabetes not a glycemic target can cost the payer up to an extra $11,000 annually, which of course comes back to the patients and all of us and higher premiums and everything. But one of the things I find really interesting is there's all this people are really looking at additional solutions, like kind of complicated solutions like digital health things and like reminder systems and connecting with different technologies and different mobile apps that can be used to improve the outcomes and tell people to take their insulin. But none of these have actually shown any evidence, really. So even though there's interest and there's people working really hard in the digital space with all of this high-tech technology, unfortunately, those solutions have not really addressed this issue. So that's where today we are going to share with you another potential solution that can really, potentially help people to take their mealtime insulin. So just some background information about CeQur Simplicity. So this is an on-demand insulin delivery system that is intended for subcutaneous bolus delivery of insulin for the management of diabetes in adults requiring insulin. So that includes both people with type 1 or type 2 diabetes that need mealtime insulin. The CeQur Simplicity on-demand insulin delivery system has been studied for use in adults 21 years and older with diabetes, again, type 1 or type 2. So at this time, it is not intended in pediatric patients. And then labeled for use are with rapid-acting insulins, and that includes the Humalog or insulin Lispro U100 or Novolog insulin Aspart U100, which are sold or prescribed separately. All right, so let's dive in and let's talk a little bit about this. So for starters, it is small. It's a small wearable device that is pretty convenient because it's wearable. And so it is absolutely, people always ask, is it waterproof? Like, can I shower, bathe with it? Yes. Please shower and bathe. It is absolutely waterproof. You can even go swimming with it. So it is meant to be worn continuously for 72 hours. And in fact, when you take it off, you're meant to put a new one on. It really is designed for ease of use. It's also designed to be discreet. So I have a lot of patients that don't want to wear diabetes on their sleeve. They really prefer to keep it private, and they don't want every person they know or they meet to know that they have diabetes. So that's one of sometimes the barriers of, oh gosh, I'm with other people and now I'm going to go ahead, I'm going to take out all my supplies and give myself insulin. So this is truly designed to be discreet, to be worn under, under your shirt. And it's small, it's lightweight, and they say it's the size of 4 stacked quarters. It seems even smaller than that to me, but it's very, very thin. And so the idea being that it is much easier, you can dose it underneath, nobody needs to see what you're actually doing. And then the third thing is that it leads to fewer injections. So another barrier I have with some of my patients is they don't like the needle. And granted, we've gotten better with this. We have smaller needles. We try to use the 4mm needles with everybody. But even sometimes just the act of like seeing the needle, injecting the needle for people is just, they have such an aversion to this. So the fact that you're only inserting this device every 3 days, you really knock down all of those mealtime injections. So you can think if someone was dosing 3 times a day with all their meals, this would be 1 device insertion in 3 days versus those 9 injections at all their meals. Less pain for those that experience pain with their injections. And 90% of users reported mealtime insulin being absolutely painless with CeQur Simplicity. The idea being that once it's on and you give yourself insulin, you don't feel any of those doses. And 9 out of 10 people claimed that CeQur Simplicity helped them do a better job following their insulin regimen compared to kind of that traditional insulin syringe or pen. So let's show you this in a little bit more detail. And in fact, I even have got a demo with me too. So this goes in 2-unit increments, and it's very clear on the device because we don't want people to get confused. It is 2-unit increments. What you do is you squeeze both of the sides to get that dose. And that's done on purpose because you could imagine you don't want someone to be moving around, get bumped, and accidentally give themselves insulin, right? So it's designed on purpose that you squeeze both of the sides so that you get the dose of insulin. And then if you don't want insulin, you don't get the insulin, right? The other really cool thing is that it's a soft, flexible cannula for insulin delivery. So some people are like, oh my gosh, wait, I'm going to wear this thing and there's going to be a needle inside me for 3 days. Oh, no, no, no. But it's not like that. You can kind of think of it as similar with CGM, right? What I tell people is that, yes, there's a little introducer needle because we got to get it under your skin, right? That needle comes right out and there's a soft cannula under the skin. It's like an eyelash. So it's very, very soft and flexible. Small profile. The corners are soft, so it's designed to be comfortable. Again, being waterproof, water resistant, so you don't have to worry about that. Now it holds up to 200 units of insulin. So thinking about it in over 3 days, even people that are on higher doses of insulin, that 200 units will be more likely to last them over 3 days. It is a minimum fill of 100 units. So if someone's on very low doses of insulin, they still need to fill it up to 100 units for the device to continue working. And for those that are on higher doses that go through more than 200 units over the time, they would just replace it sooner instead of the 3 days. And this is designed to be a bolus only patch. So it's designed to still take with a long-acting insulin. So fortunately, we've got lots of great long-acting insulin options that can be taken just once a day, like degludec and glargine. And hopefully we're not too far off from a weekly basal insulin, which would be really cool because that would really cut down on injections. So I just kind of want to show you, I have my little dog here. So I put the device on the dog, and I just wanted to show you how when you're ready to dose, right, you just squeeze these 2 sides and it gives the dose. So it's just like, it's kind of fun to squeeze it. But ideally, this would actually be underneath somebody's, it's underneath someone's shirt, and they can just do it. And it's like, nobody knows, no one, they just squeeze it really fast. And then I just also wanted to show you, because I have an old one here, when it's done. So after you've kind of used up all your units in there, these lock, so you can't press it anymore. So oh, I've already gone through all of my insulin. It's time to replace it. And then I don't know if you'll be able to see this so well, but I just thought it would be really cool to show you this like really soft cannula, how it's bendable. And I love to show this to patients in the office. Like, this is what's inside you. It's soft, it's bendable, it's not that deep at all. And so I find, like, especially for people that just don't like needle sticks and stuff, that's really reassuring and everything. So this helps to highlight how this really reduces injections. And the thing is, this is assuming 3 times a day, right? 3 mealtime injections a day. I have a lot of patients that do more than that. They do their 3 meal times, but then they're also correcting at other times. And so if you think about it, like, yes, at the minimum, this would save you from those 9 injections every 3 days. But also it really has the potential to do more than that. I mean, I've got patients that are bolusing 5 or 6 times a day. So it really, really cuts down on all of those insertions, and also all of that, like having to grab supplies, like having to use a new syringe each time or having to use a new needle, because we encourage people not to reuse those things because they become dull and then they'll hurt even more. So it really saves a lot on those injections. Now, I know this is a lot of information on this slide, so I'm really going to break it down for you. So CeQur Simplicity is really very much a new device, and it has a new FDA indication, which is what this is really highlighting here. It compares it to some of the other options out there, which I think are so important to know, because I embrace choice, that there's different choices for different people. And all I just want people to be aware of their options and to understand the nuances between the different devices, right? So let me walk you through the different categories, and then we'll go through how they differ in each one. So all the way on the left here, right, we've got subcutaneous insulin delivery. And this is the reality, is most people that are taking mealtime injections are using one of these devices. And I don't think it's out of choice. I don't think they woke up and said, this is my favorite device, this is the best for me. I think it's that these have been around the longest, and this is what they've been presented as their option for taking insulin. So we have disposable syringes, right, that we use with vials. And fortunately, we do have disposable ones now. Back many years ago, we had reusable ones that you had to sharpen that were kind of scary. I have one like all the way in the back that someone gifted me. Fortunately, we have disposable ones, but it's still having to use a new syringe each time, right? We have disposable pens as well, right? So they have 300 units, and we replace the pen with each injection. And then we have some durable pens, not quite as popular, especially in the United States, but we do have some durable pens where you still would replace the needle each time, but the pen itself lasts longer and you fill it up with cartridges, right? All right. So we've got that category. Then we've got CeQur Simplicity, which we just talked about. And then to the right of that, you've got the continuous subcutaneous insulin infusion, right? So this is often what we think about with insulin pump. This category is specifically highlighting 2 tubeless options. We also, of course, have tubed options as well, which have the tubing, which sometimes people don't like. So we have the Vigo, which is a device that is changed out every day and can deliver bolus doses in 2-unit increments, similar to CeQur Simplicity, but has some big differences in terms of how much insulin that it can hold, which we'll talk about. And then you also have the Omnipod, which is a kind of, I guess, a higher tech device that has a bolus calculator and has a separate PDM, personal diabetes manager is what we call it. So a separate device that you use to basically enter in your information, whether it's carbohydrates or whatever, and you use that to program the bolus, okay? So those are the different categories, right? So now let's go through some of these different rows here. So complements long-acting insulin, meaning you take it in addition to long-acting insulin. So of course, pen, vial, yes, you always want a long-acting insulin because you want to have some of that background insulin. If you don't have that, then what we expect is going to happen is glucose is going to rise overnight or during times when a person's not eating, because glucose is produced from the liver. So this definitely complements that. CeQur Simplicity also, right? We require a person to take a long-acting insulin, having a basal insulin in the background. Otherwise, they're they're going to have that issue. So it's designed just for the bolus dosing. So what about the V-Go and the Omnipod? So neither of those are designed to take with long-acting insulin. In fact, the V-Go actually has background insulin running. However, it's only comes in 20 unit, 30 unit, or 40 unit options. So what that means is your patient has to fit into that category where they only require 20, 30, or 40. I find that many of my patients require more nuanced dosing than that. And especially in type 2 diabetes, people tend to be on much higher doses than that. So sometimes it's challenging to find the right patient that fits in with that dosing. And then with the Omnipod, it is providing background insulin. It has basal rates that you need to program in addition to the bolus dosing, which is all programmed through the PDM. All right. Now let's talk about simple low-cost transition. So meaning if you're transitioning from a pen or a vial to this device or switching, how easy is that? What's the cost of that? So generally with a pen, if you were to go to a vial, that's going to be pretty easy. It's going to be dose for dose the same. It's actually very similar with CeQur Simplicity as well, because you're going to keep the same long-acting insulin dose. The only thing that's going to change, and in fact, you're going to keep the same bolus doses. If someone is doing 10 units at each of their meals, they're still going to do 10 units at each of their meals, but instead they're going to do 5 clicks, 1, 2, 3, 4, 5, right? To get those 10 units. But the dose, there's no calculations. There's no like extra math that anybody has to do, right? Now with V-Go, you often do have to make that because you're going to have to switch and figure out, are you going to do the 20, the 30, and 40? And then when you do transition to a pump, that is where you do need to do some math. You've got to do your carb ratios, you've got to calculate your corrections, and you've got to figure out a safe basal rate. And often you need to reduce the dose. So there's some additional nuances in training. What about the duration of action? Wearable, of course, a pen and vial is not going to be wearable, right? CeQur Simplicity is wearable for 3 days. The V-Go is wearable for 1 day, and Omnipod can be worn for 3 days. Just keeping in mind, it only holds 200 units, which is a combination of the mealtime and like the basal insulin. What about discrete dosing? Vials, pens, not very discreet, right? It's really hard to hide those things. And then people are put in awkward situations. If they want to do it discreetly, do they like go into a bathroom and like, I don't know, it can be kind of dirty in there. Do they go to their car? I don't know. It's really hot right now. So keeping your insulin in the car is not a great idea either, right? CeQur Simplicity, definitely discreet. V-Go and Omnipod also can be very discreet, can be worn under the clothes as well. Injection-free delivery, well, yeah, vials, syringes, needles, those have injections, right? We talked about CeQur Simplicity has that flexible cannula. Actually, the V-Go, the needle does stay inside you, so that is a needle. And then Omnipod is also a flexible cannula. And then the last category, the capacity for type 2 diabetes. And what we mean by that is many people with type 2 diabetes have insulin resistance, right? So they require higher doses of insulin. And so we need devices that can really hold more insulin. So yes, you can do that with vials, syringes, pens. We can do that with CeQur Simplicity because it's got the 200 that's just bolus. And then you can still do whatever dose of long acting you need to do. We talked about V-Go, how it's the 20, 30, or 40, and each day you have up to 36 units of bolus. And then with Omnipod, you know, it can be used certainly, and it is used in people with type 2 diabetes. Just something to keep in mind is that the pod holds 200 units, and that is for the background, the basal, and for the bolus. So I do have a lot of patients that they are just on a lot more insulin than that. And so that is a challenge to sometimes using that device. All right. So with that, hopefully that provided a pretty good overview of what we're talking about and the different options. Now I want to present you with some of the clinical data and with the user satisfaction. So don't worry, we're not going to go endlessly into all of the different studies. I've listed the references here, so you're welcome to peruse and look at them at your leisure and pull them up. But I just wanted to let you know that there's been functional testing, which is important to make sure Is the patch safe? Is it accurate? Is it reliable, right? Because you want to be sure when you do that click and get those 2 units that you're getting the 2 units. And indeed, the functional testing showed that when you do your click, you're getting your 2 units. So that's great, right? What about the user experience? Because we know we've got lots of choices for insulin delivery. And for the most part, like they're all accurate. They're all can get you the insulin. But what it comes down to is if people aren't taking it, if they don't want to use it, it's not going to be effective. And that's why we saw like it leads to higher A1Cs, it leads to worse outcomes, worse complications. And so the user data has been amazing, really showing higher satisfaction, definitely compared to pens and syringes. And then there are even randomized controlled trials. And this is so important because we have all these new things, these new and exciting things happening in diabetes, but some of them don't have any evidence behind them. And so, yes, it sounds exciting. We've got this new digital therapeutic, like these new things, but you want to know that there's data behind it, that it will lead to better outcomes for your patients. And so we do indeed, we have our randomized controlled trial data that has shown that it is clinically proven to reduce A1C and increase time in range. But I don't want you to just trust me on that. I am going to share that data with you because I think that is really important for you to see. So with that being said, let's talk about this. So this has been published in Diabetes Technology and Therapeutics, led by the amazing Rich Bergenstahl and colleagues. And this was indeed a randomized controlled trial. So our highest level of evidence. And I can't emphasize how important this level of evidence is. I have like such an honor to be serving on the American Diabetes Association Professional Practice Committee. And this is the committee that updates the ADA standards of care. And so I get to just have these conversations with these amazing people, and we update the guidelines. And one of the things that we look for more than anything is what is the quality of evidence? Are there randomized controlled trials, which is the highest quality and leads to the highest recommendation, A recommendations? And so this is what we're looking for in the literature. This is the strongest type of evidence out there. So they did do a randomized controlled trial, and this included 278 people with diabetes randomized either to an insulin pen or to the patch, to the CeQur Simplicity patch. And there was actually a crossover component. So over 44 weeks, they were randomized to their one device. And then there was a 4-week crossover where they got to go ahead and try the other type of device. This included people with type 2 diabetes that were on basal insulin only for at least 6 months. And basically people that were struggling to reach their A1C target, that clearly would the next logical step was to add a mealtime insulin. Baseline A1Cs for inclusion were 7.5 to 11%, age range 22 to 75 years. And they actually used a pattern-based logbook with a simple insulin adjustment algorithm to make sure insulin was titrated in a way so people could ideally achieve their A1C targets. The primary endpoint was the change in A1C at 24 weeks. There were additional secondary endpoints of efficacy, safety, and patient-reported outcomes. This was designed to be a non-inferiority study. And you'll look here at the different visits. So typical to clinical trials, these patients were followed pretty closely, especially in the first 12 months. And then you can see the follow-up visits at 24, 36, 44, and then 48 months. So what about the demographics and baseline characteristics? So pretty typical of what we see in our patients with type 2 diabetes when they're ready to start mealtime insulin. So there were 139 in each group, and they were very well-balanced groups, very, very similar groups. A good mix, I would say, of genders, of female and male. We do see there's definitely more white patients enrolled, which unfortunately is very typical of our clinical trials in the United States, and definitely something we're working on to increase diversity. But one of the nice things that you will note is under ethnicity that there were 16 to 18% Hispanic or Latino represented. So that's good, at least increasing some diversity there. In terms of duration of type 2 diabetes, around 15 years. So again, like very typical of a point where you'd say, okay, like this person, we've tried other therapies, it's now time to embrace mealtime insulin. And then you can see the height and the weight there. And if you're like me, I'm like, what does that mean? What's the body mass index, right? So I calculated it. It was around 32 for the groups. And what that means is most patients fell in the obesity category. Again, really typical, right, of our type 2 diabetes. And then baseline A1C at screening, 8.6 to 8.7% overall. So summary of patient statistics. So overall, very good in terms of the patients that completed the clinical trial. When you do a trial this long, almost 2 years, almost a year, patients often, you lose them to follow, like things happen, people move away, like people start a different therapy, like all kinds of things happen, right? But you can see the retention was really, really good at week 24. And then week 44, I mean, it was close to 80%. And then also in terms of the retention, doing that follow-up 4 weeks, those that had made it to 44 weeks were very likely to continue on to do those final 4 weeks. And top reason for withdrawal was just, patient withdrawal of consent. All right, so what were the results? What did we see? So with use of the CeQur Simplicity, A1C goals were indeed achieved. And this is impressive. So a total of 63% of users were able to reach that A1C target of less than 7% at week 24, and 85% were able to reach that less than 8% at week 24. And we know some people are just so predisposed to hypoglycemia or have other complications that sometimes that 8%, under 8% goal is really the safest goal. And these results were sustained at week 44. So you can see here the mean A1C, 6.97%. And that was sustained week 44, 6.95%. So that's actually a 1.7% A1C reduction. It was statistically significant. It was also clinically significant. This was a non-inferiority trial, so we saw similar A1C reductions between the groups, and there were no differences for reported hypoglycemia between the groups. This is showing how, in visual format, how that A1C decreased over time. And so you see here the Simplicity versus the pen, and how really those reductions in A1C, it's interesting, even as early as 4 weeks, even though normally we wait 12 weeks to check A1C based on the red blood cell, although we can still see some changes at 4 weeks. By that 12 weeks, there was near full A1C reductions achieved, and that non-inferiority endpoint was met. And overall change from baseline 1.63% for both groups at week 44. Now, anyone who knows me knows I'm a really big fan of continuous glucose monitoring. So I was really excited to see that in this trial, they had a subset of patients that were using CGM. And so they compared the baseline and then the follow-up metrics. So about CGM, right? We have something called time in range, which is that time spent between 70 and 180. And the goal for most people with diabetes is to achieve 70% or more in that target range. And that correlates really, really well with a less than 7% A1C. The reason why time in range is so great and why I'm such a fan of it is because it really takes into account hypoglycemia and glucose variability, versus an A1C alone is actually just an average. It's just an average. So you can lower an A1C a lot by causing a lot of hypoglycemia, right? So that's why this data is really important, because it lets us know, well, is that why it was lower? Was there just lots of hypoglycemia, right? So it's very impressive to see that in both groups, the time in range was well over 70% at week 24, right? So that's great. Also, if you do break it down, they did break it down into level 1 and level 2 hypoglycemia, so under 70 and under 54. And you'll see here that there was not very, very similar between the two groups. There was a little bit more hypoglycemia, level 1 hypoglycemia, with adding mealtime insulin, which is just sometimes the nature of adding mealtime insulin. There's just more variables if you eat less or you took insulin and didn't eat as much as you planned to eat. So that's not surprising. But the good news is when you look at that level 2 hypoglycemia under 54, which is when people generally will experience more severe symptoms and can lead to severe hypoglycemia requiring assistance from another, you can see in both of those groups, it's very close to 1%. So that's the goal, to try to be under 1% there. What's especially, I think, cool is that time above range though, right? So the time above 180, wow, that decreased from 50% to 21%. That is such a huge amount. I mean, before the trial, patients were only 48% in range. They were spending 50% of the time above 180. So you can see how that really came down, as well as that time over 250. They were spending 18% of the time there. And then, so also not surprising, the A1C in the subset of groups was also decreased. And then the variability, this is standard deviation, so lower is better. And what I find fascinating is that even the glycemic variability improved. Despite adding mealtime insulin, the variability actually came down. So that's pretty cool. All right. Some of you might like visualizations, right? I just went through tons of numbers and a chart, and I don't know, that was like a lot, right? So this is such a great visualization of time and range. And so look at the before and look at the after. So if you're following Rich Bergenstahl, one of his sayings is FNIR, flat, narrow, in range. So you want more of it in this gray range, right? But something I want to point you out to in the before data is look how all of those lines, they like slope down. They slope down and then they go up throughout the day. That is a typical pattern of over-basalization, where we just say, let's go higher on the long-acting insulin because your A1C is high, right? So what happens is we end up dropping people overnight. They go low overnight and they still trend up during the day because they're eating and they have no postprandial glucose coverage. So you see here, when the mealtime insulin was added, how those lines are so much flatter. So that is why when people need it, they need mealtime insulin, and that's the best thing to get them to their goal. All right, what about adverse effects? So you might be thinking, well, all this sounds great, but like, is it safe? Is this a safe thing to wear all the time? Yes, it is very safe. So in terms of comparing between the two groups, you can look the number of safety events. There's always going to be some adverse effects in every trial and not necessarily related to the drug or the device itself, right? Very, very similar between the groups. The deaths were not, very few deaths, right? One in the CeQur group, 2 in the Penn group, not related to the devices or the insulin themselves. They were cardiovascular related. And then very, very few that led to actual treatment discontinuation. And in terms of the ones that were related to the device, very minimal types of things, like some people don't like to wear devices or reported itching, but overall very, very minor adverse effects. And the hypoglycemic events were the same in both groups, which is just, the nature of insulin, right? All right. So all of that also is great. And I know when I looked at this, I was like, well, like, why were the groups similar in A1C? Like, how did they have the same A1C reduction? And I think when you're in a controlled clinical trial situation where you've got a whole team and you've got this insulin algorithm, we know insulin is effective and we can get to goal. So where it really comes down, right, is the user satisfaction and how that would translate into the real world. Because outside of a clinical study where patients aren't being followed so closely or getting free supplies, are they likely to actually do this and to actually follow this? And so this was based on patient-reported outcome data showing that there was very high overall satisfaction with the CeQur Simplicity, satisfaction with ease of use. 88% of people reported that helped them to do a better job following their insulin regimen. They also surveyed the healthcare professionals that were involved, and they said that they preferred the product to pen to advanced people on type 2 diabetes to basal bolus. They were very satisfied with the device and found training of the people was very, very easy. And you can see here the subject reported outcomes compared to pen. So remember, they wore both devices, right? So this is showing that 75% were satisfied with CeQur Simplicity, 72% preferred CeQur Simplicity. That's a lot, right? And 71% would recommend CeQur Simplicity to others. I just want to show you one more study related thing, because that was a randomized controlled trial, which again is the highest level of evidence. But we still like to collect real world evidence. Like, a lot of people are prescribed this now. How are people reacting in the real world? So they actually have been collecting survey results, and this manuscript is not published yet, but hopefully will be in the near future. And so what you can see is people reported out on their insulin delivery method satisfaction before Simplicity and after. And it shows you here, so higher is better in that category. We can see how that rose. Interference with activity, so lower is better there, meaning it did not interfere as much with their activities. They reported better clinical outcomes. Diabetes related worry, so that also improved. Lower is better in that category. So people have less worry. That's important because there is a lot of diabetes related distress. And we have so many things to already stress about. We don't want to add additional stress for people managing their diabetes. And then I love to see this psychological well-being was actually reported to be higher. And then you can see the different satisfaction marks, and 95% of patients said they were completely or very satisfied with their Simplicity compared to 35% with their prior method. And 93% of patients said Simplicity is better than their previous method. All right, so hopefully that data helped to reinforce what we talked about. So how are you going to get this for your patients, right? So fortunately, you can just prescribe this to the pharmacy. And as a pharmacist, I just especially love that, right? It's always easier when you can get things at the pharmacy. It is a 2-unit patch designed for 3 days. So you're going to go ahead and wear it. You're going to need to get 10 for a 30-day supply, right? Also, there is an inserter, which I also have here. So you only need 1 inserter. You can keep reusing this thing. It's great. And so you would want to make sure you get that 1 inserter to start with, and it comes with a quick start and a user guide. You do need vials of insulin. So making sure you prescribe a vial of insulin, either Humalog or Novolog. And then for training, you've got a couple options. So I love to train my patients. We can do training in my office, but we understand not everyone is equipped for that. And fortunately, the CeQur team has a phone number that you can call and actually get them set up to get the training. The training is really fast and easy. It's like less than 30 minutes. So, but there's that option too, if you don't have time to train in your office for how to use it. So just some summary points. So this is really designed to simplify the lives of people with diabetes, which lives are already so complicated. So it's good to have a simple option. Patients using mealtime insulin are often not at goal, and so we do need additional strategies to help them meet their goals. We talked about how missing mealtime insulin really can lead to poor glucose management, increased A1C, as well as reduced time in range, which translates to diabetes-related complications. This is a device that can really help address many of the barriers that people have to taking their mealtime insulin. And it has indeed been shown to reduce A1C as well as really increase that time in range. And we also know that improving adherence to taking insulin has been shown to improve health system costs, which eventually come back to patients and health systems and clinics. And we saw how it's preferred by patients over insulin pens or vials. And then there are a couple of resources. There's a NIPR-RX specialty pharmacy as well that can help facilitate it. And you can definitely connect with your team in your local area to determine like the best pharmacies to send to or the best ways to be able to get it for your patients. And with that, I'd love to go ahead and open it up for questions now.
Thank you, Diana. And it's just amazing to see how much passion you bring to your profession. And we do have about a little bit over 10 minutes, and we do have Curtis there in the background, able to address any questions that come in via the chat box. But as those come in, don't have no fear. I have some frequently asked questions, and we'll start with that. But please feel free to type in some questions. So Diana, can the patch be refilled or reused?
No, don't do that. So it's designed for one-time use. Fill it up with, 100 to 200 units, and then once it's done, you replace it with a new patch.
Another common question is, does the patch come preloaded with insulin?
No, so that's why it's important that the person has a vial of insulin, a prescription for that. And so you do need to fill it up. And sometimes that's part of the training that might be new for people coming from pens. But yeah, we teach patients to load it with the insulin, which is pretty simple to do.
And I know you covered this next question very thoroughly, but it's a good refresher. How much rapid acting insulin does the patch hold?
Yeah, so 200 units, and there is also about 20 units is used to prime it. So kind of keeping in mind about 180 units of active insulin the person will have to use over the 3 days.
And what types of rapid acting insulin is the indicated?
Yeah, so it's specifically been studied and indicated for Humalog as well as Novolog U100 insulins.
And you covered very thoroughly, type 1 and type 2 diabetes. If I can add it, so we were only studied for adults over the age of 21. Another common question we do get a lot via email, social media, etc., is CeQur Simplicity used for gestational diabetes?
So that is a great question. So, because I do a lot of gestational diabetes management. So it's not technically, there's not like a specific pregnancy indication. However, we often use Humalog and Novolog in pregnancy, and insulin's our first line medication for use in gestational diabetes. So if a person requires that type of insulin, there's no reason why it couldn't be an option. And in fact, I have had patients that were like, gosh, I cannot deal with these injections. And so that provided a method to be able to add mealtime insulin without adding all these additional injections.
Thank you. And here's a question that when I first joined this team, it threw me a curveball for me. So can patients use CeQur Simplicity if they dose in odd units and 1 unit increments?
Yeah, so unfortunately, no. I mean, it's 2 unit increments. It's really designed to be simple. So yeah, if someone needs 5 units, they're going to have to round to 4 or to 6. And so there are people, if they're really, really sensitive and they need like 1.5 units or like 3 units, then this just may not be the best option for them.
Well, it's a great thing that there's a lot of options out there, right?
Definitely. Yes, love the choices.
So you also covered this pretty thoroughly, but what happens when the buttons are locked? Like what should a patient do?
Yeah, so it's so cool because I have an example here where it locked. And so what you would do is you would go ahead and remove it, you take it off and you just peel it right off, and it would be time to replace it. So it could just be, you've used all the insulin in it. And it's really nice it does that, because you wouldn't want to think, oh, it's still giving me insulin, but it actually is not, right? So that's designed as a safety.
Yeah. We do get a lot of questions if there's connectivity, right? So as Diana mentioned that in the presentation too, there's no connectivity, but that's one of the safety features that our device has, is when it's out of insulin, it's going to lock.
Right.
Okay, another question is, I'll skip this one. You covered our Secure Care team that could help with training, but one question that we can partner together is, of course, insurance coverage. So currently, we have great coverage both in commercial and Medicare Part D insurance plans. And as a reminder, it's a pharmacy benefit. When covered, 2/3 of patients have a copay of $50 or less a month. And we think that's very fantastic, for the early stages of our device. And of course, individual plans and pharmacy benefits vary by patient, but please feel free to contact us at CeQur Care if you have any questions about cost and coverage. We're here for your support.
Yeah, and I would just add, I've been like very pleasantly surprised or pleasantly happy with the coverage and my patients being able to access it. And the CeQur team's great. Like if you have any issues, you send it to the pharmacy and you're like, oh, I'm not sure where it is. They can help you with that.
Awesome. And one big question right now that it's getting hot and a lot of outdoor activities and a lot of sweating out there in those humid areas like Ohio, can patients wear CeQur Simplicity during normal daily activities? Is it waterproof? Any tips with that in mind?
Yeah, no, it's definitely an issue, right? And that's one of the reasons, like another one of the advantages, because like I just see people like storing their insulin in their cars and it's like 1,000,000 degrees. It gets so hot in the car and that's so bad for the insulin because it degrades and it doesn't work as well. So it's protected when it's on the body. I mean, it's protected and it is indeed, it's safe to wear during all activities, even swimming and everything. In terms of adhesive, it's always a concern, like is something going to fall off early because people are sweating a lot. One of the things I just really encourage is make sure your skin is very clean and dry when you put on any adhesive device. Make sure you use plenty of alcohol and just make sure it's dry, clean of dirt or anything so that it has the best chance of really sticking on very well and making it the whole 72 hours.
Thank you. So on the, with the topic of adhesion, so per our label, we do, patients can augment adhesion by using medical grade adhesive bandages or tapes. Suggestions of examples are Hydra tape and micropore surgical tape to place over the patch's adhesion. And I'm curious to know can you walk me through how you have that conversation with patients when they ask you if the patch tracks insulin doses?
Yeah, so it doesn't track insulin doses, and I'm very upfront about it because we have a lot of amazing technology tools that track things, and now we have connected pens, and I mean it's nice to have data. Like data is fun, but I have a bunch of patients that really just don't want that. Like they feel like, okay, I know how much insulin I'm supposed to take. Like I don't want like something I don't want another mobile app to put on my phone. I don't want like all this complications. Like I want something simple. Like I just need to take my insulin, right? So I think just being upfront with them, and that's where the patient choice comes into play. Some people want like really high tech, really fancy, really connected, like 10 mobile apps. And other people, actually, there's several people that like really don't want all of that.
So we do have a few more minutes for a few more questions, and I'm going to scour through the chat box to see if there's anything that we haven't addressed yet, if that's okay with you, Diana.
Yeah, I see someone has asked a question kind of about the ordering of the insulin. And so I think that's a good point, because when you're prescribing the insulin, you do know that you're going to need a minimum of 100 units over the 3 days. So you would want to write for over 30 days to make sure that there's enough insulin to do that. And if the person's planning to use the 200 units or needs a higher dose, then you're going to calculate how much is needed over the 30 days and make sure that you include that full amount. And I usually try to include some extra, because with mealtime insulin, some days someone might need more or something might need less. So I try to write for a little bit more.
Okay, thank you for addressing that question. Let's see what else we haven't addressed here. So I see a question here: is it being sold in more pharmacies besides our specialty pharmacy, Nipper, and Walgreens in New York? So we don't have a New York rep yet, but hopefully that's going to change very soon. What I can do as well is send everyone that's attended today specific prescribing instructions and guidance based on where you're located. And I'm happy to do that after today's presentation.
And I see someone asked about the training, and yes, generally the training is like maximum 30 minutes, because it's basically learning how to use this little insertion device, which is not too hard to use. And then if for those that aren't familiar with using like a vial and syringe, that's where you may be spending a little bit more time just getting comfortable with that. But generally the training it's much faster than like what you would expect with like a full-blown insulin pump or something like that. Like this is much faster.
So one last question to respect everybody's time is, what is the barrier to extending the days that CeQur can be implanted or worn after 3 days?
Oh, you're gonna ask that to me. Well, I think it's been studied for 72 hours, and that is the duration. Like when you compare that to like insulin pumps, Omnipod, most of them it's 3 days. And so there's some concern that there could be, actually there's some concern about the insulin degradation too, that beyond the 3 days, the insulin may not be as potent, it may not work as well. Certainly, there's efforts out there to study different products for longer, but at this time, that's what's been studied, and that's what we can guarantee would provide safe and effective and accurate insulin dosing.
So to reinforce, yes, our indications only for 3-day use. So with that being said, I do want to respect everyone's time. Thank you all for attending. We have folks from nationwide, from various states. And last but not least, I want to thank you, Diana. It's always a pleasure working with you. It's been great getting to know you more and more. And thanks again.